Hi, everyone. So it came to my attention that the lecture had cut off, so I'm re-recording the last few slides of this lecture. I apologize for any inconvenience that this causes you. So the last few slides will cover time to event studies. As I hope you recall, these were discussed to some degree in the biostatistics lectures when we discussed Cox proportional hazards modeling and hazard ratios. But as you can imagine, time to event studies and understanding time to event outcomes is very important. You hear this a lot with prognostication when people are diagnosed with certain diseases. So you hear about 5-year survival when people are diagnosed with cancer, things like that. But this really could be length of time to any outcome. So death is often what we discuss, but it also could be how long it will take before some maybe cell or abnormality progresses to cancer or other types of outcomes like that. And so what you really want to know is once you start following people, how long until, what is, events occur over some time. And this is often expressed using a survival curve. And so I think we already talked about this again a little bit in the biostatistics lectures, but you can create a survival curve where you start with basically people that are outcome naive, and then you follow them up into to a specific time to see how often, how many events occurred over that time period. And so these survival curves are often called Kaplan-Meier curves, and you've seen them before. Excuse me. So often you start with, so you rather not often, you always will start with 100% of people alive at the beginning, or at least 100% of people that have not had. So this is called survival analysis, but again, it could be towards any event. So 100% of people without the event, and then you follow them forward, often comparing 2 or more treatment arms. So here you have a study drug and placebo, and then as people follow forward, you can see how the curves will separate. You'll see here that on this figure, a couple of things just to orient you. And so you'll see that this is time over months. Note that sometimes, and we'll talk about this in a little bit, that sometimes figures in published manuscripts will break the y-axis, and so be aware of that. That sometimes the curves are exaggerated. And also, you'll see at the bottom there that they show the number of people that are remaining in the study, and that the numbers get really quite small over the course of the study. And so, they certainly can. And so, just to pay attention to that. You also see that there's a hazard ratio with the p-value here. And so that hazard ratio, again, we talked about hazard ratios and Cox proportional hazards modeling. Sometimes you'll see what's called a log rank p-value, and that's testing the null hypothesis that these curves are the same. And then so if that is statistically significant, then that'll tell you that the curves are significantly different. So again, these are called Kaplan-Meier survival curves. And again, you're going to use follow-up data over time. And what this is actually estimating is the conditional probability of surviving, of not having the event at those specific intervals. And so some things just to kind of to be aware of, that what Kaplan-Meier curves are also doing is they're statistically looking at these data, and then when people have a specific event or are censored, they'll then drop out of the denominator. So we talked a little bit about censoring as well in the biostatistics lecture, and we'll do more on the next slide. But basically, these are people that are lost to follow-up, and so they actually haven't had the event, but they but they are no longer in your study. You are not following them. And so they also can no longer be included. And censoring is an issue for obvious reasons, that it may reduce sample size and the reliability of your estimates. So here again is another example of a curve where everyone starts, the proportion that's surviving is 100%. And over time, you'll have people that are surviving and also people then that are censored, and these censored people are dropping out as well. Okay, but as these people are dropping out, there'll be an adjustment for these people leaving the study. Some concerns about censoring is that we assume that it's part of random, but it's not. As you can imagine, once we lose people to follow up, we don't know what happens to them, so we don't include anything after people are censored. And the concerns here are the reduction in sample size and potential imbalances in the groups. Here's another example of a survival curve. Again, some things to pay attention to here in this example. The first is that, I think people are naturally drawn to the end of the curves. And so this is where you're seeing kind of sometimes often big differences between the curves, but that when we should be looking, but be careful, because again, we're starting to talk about relatively small numbers of people, okay, compared to the, 4,400 people that started this study. Now we're talking about 230 that are here at the end. Here's your long-rank p-value that I mentioned earlier, which is again testing the null hypothesis that these curves are the same. Again, look at this axis break here. So this is actually starting at 80% alive, and so it's really exaggerating some of the differences that you would actually see in this curve if this was already if this was from 0 all the way to 100. So this is the last slide of the lecture, and again, I apologize, this was cut off earlier. Some things to consider when you're thinking about clinical relevance. Again, make sure you consider the MCID when you're interpreting results. Just because something is statistically significant does not mean it's clinically significant. And so remember those figures where there was where you actually had your point estimate from your study and confidence intervals, but how those where those were relative to what the MCID is for that outcome. And I think these types of endpoints like subjective outcomes and surrogate and composite outcomes, I think we talked a lot about some of the weaknesses that they often will be used in studies for the reasons described. So they do actually have a role, but you just again want to have some level of skepticism. I think especially around composite outcomes and making sure the surrogates are really good, actually surrogates for the true clinical outcome that you're interested in. Make sure that there's strong justification for using these outcomes. Be very skeptical of the composite outcomes that include a number of individual components that would either not be similarly related to the exposure of interest, or just aren't really comparable, like including mortality with some of these other things like admission to the hospital. And I think statistical power is really important, and so to be able to see a significant result if one exists, okay, but that doesn't necessarily justify using the wrong outcomes. In fact, it doesn't justify using the wrong outcomes. So it's really important to get the right answer to reduce patient morbidity and mortality. So that's it for this lecture. Sorry again for the not having this complete earlier.